Case number 6, Dr. Kini, here you are with Dr. Baber, I see. Yes,
Yeah.
great.
Welcome to the panelists, and I just have to say the 20th year of our CCC Live Symposium is something really special event. Just to say, in the interventional cardiology, you see women moving up the field. So you have a woman operator, you have a woman moderator, and you have two strong internationally famous women, which is Cindy Grimes has just joined the panel, as well as Marie-Claude Modis, who is in the panel. So I don't think you will have any other meeting with that kind of female faculty representing.
That's right. How do you like that?
meeting.
How do you like them apples?
We want applause.
All right. Give us case number 6.
Yeah, this is, you see QP, 70-year-old female, who actually again presented last week to the outside hospital with unstable angina. Troponin was negative. Risk factor-wise, she does have atrial fibrillation, diabetes, and most of the ischemia was on the lateral wall. So she was on good medical therapy. She did have a cath at outside hospital, which showed she had distal left main disease, proximal LAD about moderate, but most important was a significant circumflex disease with a syntax of 26. In the outside hospital, heart team discussion was done. She did not want surgery, so patient was referred here to have the PCI of the left main. So here we are. EF, near normal LV function, right coronary artery, prior multiple PCIs, but all the stents are patent. And this is the left main moderate, which I think here you can see it about 60% or so. But most important in the cranial view, this is what you're going to, you're appreciating the significant osteal circumflex disease, and also the amount of calcium that you will see in this
That
case.
gives me some pain looking at that view over there.
This is the amount of calcium.
Lots of calcium.
Yeah.
Sounds good.
Wow. Marie-Claude, what do you think? Impressive, no?
That it's a very complex case, as usual. Even entering in the circ will not be easy.
We agree.
It's a very nice educative case, and I'm looking forward on what they will do.
Yeah. So I see already you put a balloon pump in. Tell us your
So what
reasoning.
actually happened is when we had seen the angiogram from the outside hospital, it was a different looking circ. But I think in the last couple of days when we saw this angiogram, she has distal left main and a calcific almost total circumflex, and that's when we thought this is a kind of angulated circumflex. If you have a difficulty in wiring, especially if you have a vessel closure when you're wiring, that she will need balloon pump assistance. So we thought while we are waiting that we will have a prophylactic balloon pump.
So in the last case, before you go, in the last case, John Fox said, how about doing some hybrid revascularization? So if your patient is refusing bypass, how about, I know we're going to undertake the hybrid protocol here at Mount Sinai, which is a protocol that's an NIH approved protocol with John Pluskis and Anatine Jellins. But what do you think? Is this a good patient for that? Is that something that you might even consider doing a lima to this LAD or a hybrid operation, or you think you're going to be able to take care of all of this in one go around of a PCI?
I think when you are doing a hybrid case, it has to be a complex LAD rather than a complex circumflex.
Excellent, yeah.
So this will not be an ideal case for that procedure. Usually they prefer just a lima to LAD, and the rest of the vessels we will do the PCI work. So here, as you see, the complexity is all circumflex. That worse comes to worse, you can stent across the entire circumflex and leave the LAD alone and come out.
Okay.
But I think the important point here for when you're starting this case, that other than that if the circumflex is likely to close, you need to think of how are you going to wire this angulated circumflex. So just to give the points how that we would handle it here is that you go with any kind of over the wire, whether it is a fine cross, micro 14, any kind of the catheter that is available out there, or even a over the wire balloon. And then use your first wire should be polymer coated wire which should be fielder. Even if people want to use a fielder XT, it's not a wrong choice in this case. And be ready with your CTO wires, that if you're not able to cross this with your fielder, that you will have your specialty wires ready, which should, people may like Pilot, but could be Gaia or Miracle should be ready with you to get the circumflex wired.
Okay, so can we watch you wire this?
Yeah, so this is our, if you see that, I just went with the fine cross I have, and with the fielder wire, able to get into the circ.
Nice.
So the amount of calcium there, the fielder was able to negotiate.
Did it really take that short of a time?
Yeah, it was 2 seconds. Everybody's here watching me. And then the next point is that yes, amount of calcium is there, that we plan to do rotational atherectomy. What is the burr that you want to select? So one of the tests that we normally do is you have a fine cross, the fine cross cross the lesion. In that case, I think 1/5 burr would be an ideal case. But more important here, we know we do not have the rota wire. You see that? Because of the calcium and tortuosity of the circumflex, we were not able to get the rota wire all the way distally. In that case, this is the ideal case where you want to have a rota extra support wire rather than using a rota floppy wire. So we do have a rota extra support wire there and a 1/5 burr ready to go in the left main.
All right.
All right. So let's go do this, and then you'll tell us, you'll guide us when you want to go to the next case, Dr. Sharma.
Yeah, no,
I'm waiting for you.
This is the case, as you saw. It came from other place actually. They wanted to do surgery, which could be fine. But again, many times these patients are the one which make a final decision what to do. And with that note, patient is here with a 1.5 burr, which we are starting now. Although we don't have much purchase, so I have to be a little slow. Yeah. We put a balloon pump, although EF is near normal. She had a just very small non-STEMI troponin positive that we thought that if circ closes, will give rise to a problem acutely.
Yeah. So
in the RCA picture, you could see the collateral to the circumflex.
yeah, we saw that as well. Any comments from the panelists at all? Yes, Dr. Lasala.
Yeah, I think the point that Dr. Kini mentions is very important to reemphasize, and that is on these subtotal, heavily calcified lesions, that you have to be prepared to do it as a CTO. Now, they were very fortunate and skilled, obviously, to get down with a relatively, a workhorse type of wire. But you have to not only have the wire backup, but I often use more of a more durable microcatheter, like a Turnpike LP I've gone to more frequently, to spin through there and get through these high-grade stenoses, because without getting it through, of course, I can't get a rotoblader wire in. And once I've done that, I don't usually have to use a 125 burr, too, because of the diameter of that catheter would mitigate against using something smaller.
You did.
Yeah, so it's so tortuous that sometimes you do have to spin. Any of the, a lot of the CTO catheters, I noticed they have to spin, especially if they're subtotally occluded and calcified. I'd be a little concerned about the second lesion. It's so, its proximity to that sharp bend. If the rotoblader jumps through there, I'm afraid it would dissect or perforate. So, taking your time, going slowly would be essential.
Dissect or perforate or even stall. If you hit it just right, get halfway through there and suddenly it decelerates, now you're stuck because you can't get it spun up again.
Okay. You saw it a very controlled movement, no jumping. It's a very tough angulated vessel. Now question still comes that what we should do for the main LAD, left main to LAD, which is also moderately calcified. I'm sure we do the IVUS will be a big, by definition.
You want to use this bar? You see how the circ behaves?
Yeah. No, but if we need to do, we do a, let's see. Because if we need to dilate the ostium of the circ a little bit.
Yeah, would you dilate the ostium of the circ before you start rotational atherectomy in the
LAD? So we have to do a little
LAD?
balloon there, and then use maybe 2 burr from left main to the LAD, proximal LAD.
I think if you dilate, we may lose the circ.
Could you show the other view of the circumflex, because that did show that proximal lesion much better.
Yeah.
Which view? The cranial? You want the cranial
Yeah, it
view?
was
Yes,
the
the
cranial
cranial
view,
view.
the elaeocranial, I think.
1744. That's where it showed it.
It looks like you got nicely through the second lesion for
Yes.
sure.
Yeah. No,
It's
so
the
yeah, both
ostium.
lesions are taken care, yeah, of the circumflex. But
Yes.
now the LAD, see that it's a tram track, very calcific left main to LAD. It's the same. You can do IVUS you want to the any time, IVUS OCT, but this was a clear-cut case of the severe calcium of the distal left main to the proximal LAD.
I think
Yeah,
angioscope
the
might take care
osteum
of
is
it,
much
no?
better. Huh?
Yeah, I might do an IFR the LAD. It doesn't look, I mean, it's hard to tell because there's a series of lesions, but even after the second diag,
we
there's a
won't go
lesion.
further. No, we are just talking about at the level of the left main. Yeah, we are not going to go further down into after the diagonals, and so we just concentrate on the at that level.
Dr. Sharma?
Yeah.
Are you concerned about now, if you decide, as you suggested, to dilate the circumflex and then rotablate the LAD? Are you concerned about losing the access to the circumflex?
Exactly
that's
what
what
I just
Dr.
mentioned.
Kinney
Neela,
was saying.
That the significant disease we went in the diag.
Yeah.
That significant
That's
disease.
fine. Leave it.
Can I have the fluoro?
Yeah,
Let me have
good.
it.
Good. Yeah.
So just to,
Yeah.
sometimes...
No, but you're right. That is always the question, the concern comes in these complex cases, that even if you've done the rota, but it's a bifurcation, other vessel is also calcific. But I would say that if you have done the good balloon dilatation, and there is not much terms of, it may have little dissection anyway, but not any significant dissection, it will be, no.
Filter for the
Yeah, so that you could just take the wire out, put a wire into the main vessel and then do the atherectomy. So I think in this particular case, because of complexity and knowing that the tightest lesion was the left main to circumflex, which has been taken care. So nothing wrong in that particular case would be that if you want to just do a balloon or let's say flextome 3.5 and see if you have expansion at the level of the distal left main to the LAD, maybe avoid the rotablation of the LAD. And if you cannot expand it, then I would say clearly open up the ostial circ anyway. And you want to go to other view?
No.
Okay, good. Yeah.
But just to think of it a different way for the hybrid, sometimes you can create the stenosis in the LAD. So if you come in here and just treat this as more simple circ disease,
I'm gonna take out the
stenting
rotavirus.
from the LAD into the circ, you'll shift black over, and then to come back, and you can do a robotic
Can I
lima.
have the fluoro, please? Yes, yes.
Yeah, but I mean, I think, at this point, when you're seeing this, you probably want to proceed, but it's a very, very good point.
Yep.
Any other
Good.
comments?
Okay. Now you
Eduardo?
give the balloons.
Yeah, let's do the ostial circ first, because that is we need to do that even if we plan to do a rotablation of the LAD. So this is the first thing we are doing. The fielder wire is back.
We have the fielder wire to the circumflex. We took the rotational atherectomy wire out, and then we have a run through in the LAD.
Ready here? No. Yeah.
Okay.
IVUS we have ready also. Anytime we feel like, and of course we'll do, that we are ready to do the IVUS run.
So I'm seeing again IVUS. When would you ever use OCT for anything in this area? Because I keep hearing everyone wants to use OCT now to,
Yeah, but
all the data is for IVUS.
No,
but
let's ask the question to the panel.
Yeah,
Yeah.
panel. This is what I'm asking. Can the panel tell me when do you ever use OCT at all for? Stefan, do you use OCT? What do you think? What do you think we learn more with OCT or?
Well, I think here in this case, this is not a case where you like to use OCT because you already couldn't pass it through the lesion, for the pre-lesion assessment. But I think where OCT is excellent is in any kind of stent failure you may have. I think it's also excellent if you want to look at the stent apposition and so on. But here, the pre-lesion assessment of the circ would be not possible.
Carlo DeMario gave us a beautiful talk on IFR. Do you ever use that? Would you ever use that in this LAD, Dr. Sharma? Dr. Sharma.
Yeah, Dr.
IFR. For
Yeah,
the,
we
for
could
the
use
LAD.
IFR for the.
Would you for the
LAD?
LAD?
But
Yes,
after that,
IFR or yeah, but you have to open the left vein first.
Yep. So there are a lot of disease in the LAD, but so I think IFR after opening that will be okay. Now question is always the OCT. Remember in my the top 10 I kept OCT because we have two major trials. You need to advance that wire a little more. Yeah, the two major trials with the Illumin 3. Again, comparing all three, there is no convincing evidence that clearly I know that Illumin 4 is already being planned with the OCT and the angiography guidance in the complex cases. But clearly we saw, and the same in the doctor's trial using OCT, you get a little better lumen or better FFR in the group, but still, does it translate? Just like which is done with the IFR and FFR, does it translate to the real good outcome? So that is biggest issue remain. So OCT pictures are beautiful. For the, as just send a statement made by I think Stephen that good for the understanding the mechanism of the stent failure, but really as a day-to-day routine of your practice, how much it will help. I still need to be convinced. Not saying that it works or does not work. I just need to be convinced by any of the data.
So tell us what you got there now.
Now this is a 3-5 angiosculpt balloon. We are
At
going up
20
to 20 atmospheres.
And seems to be okay.
Yeah, it looks like you dilated it, and
down.
with all the tram track,
Yes.
you were still able to get
So
it.
we do.
So maybe you don't need
Yeah.
rotablator in every case, Dr. Sharma.
No, but this circumflex was so difficult.
No,
Sir, could have
circumflex,
been
no
done.
question, but maybe in the LAD, I like the idea that
Ostium, no, pull back.
I think the historical data with IVUS and arcs of calcium is what everybody really reaches for when you're choosing to decide to do rotablator too.
Because same thing, I can tell you that you do OCT and there is no clear definition with the OCT what is severe calcium. We know at least the arc of calcium and the IVUS tells you moderate calcium, severe calcium, whether 90 degree, 180 or more, and so it definitely tells the depth of the calcium, which IVUS doesn't tell. So I think it's a lot of issues. But again,
but there is we can use a quadrant, whether you have 1 quadrant, 2 quadrant, 3 quadrant of calcium, the same thing, even with the OCT definition wise for a calcific lesion.
So let me understand your strategy here better.
Yep.
You're going to go 2 stents here, it looks
Yes.
to me.
Yep.
We have a lesion distal to the left main in the circ that
Yep.
really definitely needs to be treated. You treat that
we'll
first,
use the
right?
long
Or
stent
not?
in the circ.
Can you
We'll-
show us?
Yeah, we'll take this picture.
The question with the long stent, we just want to make sure that it will make a turn.
Yeah,
We do
that's
have
what.
a 24 millimeter stent and we have a 28 millimeter stent.
Yeah.
We want
go
to-
to caudal view. Make
Yeah.
sure the wire is distal,
More wire
does not go
distal, yeah,
distal.
if you can.
or
It's
as
not
long as it has
distal.
crossed that lesion. Are we okay there?
No. It crossed a lesion.
Yeah.
May not the stent, may not go. The long one.
Tell them that there's room.
Yeah, it's
Okay.
so tortuous that the Y doesn't want to
Guide
advance.
wiring, everything. Yeah.
What's happening with that wire?
Yeah,
Maybe you need
that
a new
circ
one.
wire is misbehaving. Okay,
Yeah.
this is the view where we have to decide the length of the stents here.
You want
Right.
to put another different wire?
No, I think we'll be
Actually,
okay.
I've been very much impressed with the Boston Scientific Marvel wire also
Go.
in these situations. You can put a Marvel side by side and then take this wire out.
So tell us about that wire, Dr. Sharma.
Yeah.
Which wire you're talking about? The Boston Scientific?
Yeah.
Which wire?
It's all the new class of wires. Many of them, they come and go. Looks like this may stay.
You think?
And, yeah, it's a more kind of hydrophilic competitor to our the fielder wire. But I saw it. It keeps the shape, retention of the tip, and you can use it in multiple areas. So now you'll see here, this wire should go very nicely, and then it gives a moderate support. One of the big issue remain with the fielder. It's a great fielder will go into various of this tortuosity. But once you talk about the support of the fielder, that's where I would say a little gets the minus point.
Okay. Well, let's see how this behaves. Dr. Matthew, any Matthew,
I
Samuel?
want to make sure
Dr.
again
Samuel?
the point of the OCT that all the cases which we did, 90+% cases of the absorbed, we did with the OCT. So where we know that is the as dissection, stent expansion, all those things are very important. That definitely the OCT is your best bet. Beyond the data we get from IVUS, and now actually Samuel, Dr. Matthew can answer the question. If not, you just
I mean, as far as the OCTs are concerned in left main, I have no hesitation in using it at all, because you get as much information as the IVUS is giving, even if it is calcified. It's mainly, as Kini said, it's the arc what we are looking at. That information is good enough to decide.
Done?
And even in 4 or 5 millimeter arteries, visibility is quite good.
How can you
Proximal
at least the one is making a turn there.
quality
Get us
of
a
the
stent.
picture is excellent.
Okay, good.
Yeah. It looks like that new wire didn't do much better.
Yeah.
I
All right,
think,
we'll try again.
I
Yeah.
think,
Okay.
I think Sharma, Kini didn't like the wire.
I know. That's it. The next one, I'll do it.
When you don't hear any comments from me,
Yeah.
No, you didn't like it.
Yeah, that's it.
give me.
So now you're going to use are you going to use the angioscope in the circ as well before
No, I think it opened up
stenting,
well.
or you think
We
it's
opened up
open?
well.
I think that opened nicely.
So we have a 28 stent. We have a 275/28 going to the circ.
Is the Promus?
Yes.
Okay.
275. You think
And
you're
then we have a
underestimating the
30.
size of that circ?
30, what you want? 20, 16,
3
20. 35, 35. Sorry.
35. 35, 16.
Okay.
35, 16.
I know, but
Yeah, that's
this
good.
one I was a little concerned about 28.
Yeah.
See that?
Yep.
So I wanted a
Yeah,
24.
yeah, let's get 24. Take it out.
Yeah.
Yeah. Yeah, 24.
I said 24.
So 24, but
Yeah, 28 was a little
275,
too
Are
big.
you being too cheap for the vessel? Maybe it's a 3-0,
No, it's sticking too much in the left main.
Okay.
Yeah. Yeah, because key is that it will be a big crush.
Yeah, you don't want that. You want a mini crush, right? You want it as low as possible. Any comments?
Yeah, I'm not opposed to the 275. I think I like to stent to the distal vessel, and you can always post-dilate.
Post-dilate it
Yeah.
higher up.
I've
yeah.
seen too many
Good.
vessel dissections and ruptures.
me
when you-
Especially in that
wire.
distal area where she doesn't have the wire in the
recross?
best possible place. You're right. You're absolutely right.
Sharma,
Yes.
I mean, we all know that the highest restenosis rate is when it involves the circosteum.
Yeah.
Do you have any trick to reduce the restenosis?
I think it's the same is that we need to have a little more aggressive debulking. You have opened it nicely, you're right. It always has been the Achilles heel in these bifurcation cases.
Some dye here. No. I think it's this also too long, SS. Very bad.
Yeah.
No?
Does it not want to go down distally because you just don't have good wire support down? There you go.
No, that's okay. That's all right. Yeah.
You want
Good.
to leave it
Use
like
the other
that?
one, yeah. That's fine.
It's too much crush, no?
Yeah.
Okay. Get us a 3, 5, 16 now.
Yep.
Dr. Matthews, you are asking something.
Yeah.
to
Question,
reduce
what
the
do you do with
restenosis of the
circumflex
circ?
Circumflex ostium, same. Even after you have done the rotational atherectomy, using the cutting balloon, then use a high pressure. So clearly, the preparation of the ostial circ is the most important in these cases. And also when we are doing a mini crush technique, that we have gone to the distal strut, so it has been opened nicely. So all those factors.
Is there any difference between circ to left main or LAT to left main?
Yeah, I think
Depending on which vessel is larger. Right?
fluoro. Yeah.
Good,
Ready?
Sidney?
You want to go? Okay, good.
So not to, let's show us this, and then I'll tell you about
I'm
our
going to circ.
timing here.
Okay.
This is a circ.
Circ. Okay. I'm deploying the circ now. We are going to take the circ wire out after the deployment.
And you'll need a new wire. This wire has done its job.
16.
Down. Go up again.
Is there any data that twice expanding the stent makes any difference?
Well, yeah, that's a good point. I can tell you that we adopted that policy from Washington Hospital Center when I went many years ago. It was basically, idea was that your first inflation, your stent is expanding against the resistance of the plaque. So second inflation, ideally, I mean theoretically, I don't know whether there is clear-cut data of the IVUS, but it makes sense that you'll have now the better, more circular expansion. Now, is that true? I think it's true. It's become a habit. And we are not corroborated or confirmed or disproved that hypothesis by doing the IVUS after single inflation versus two inflation.
Yeah.
I think that will be a small good project for the fellows.
So, Dr. Sharma, I'm reminding you we have 12 minutes and
Yep.
still haven't started your case number 7. I
Yeah,
know
yeah.
you're miraculous, but I want to make sure we
Yes.
make it to lunch on
Yep, yep.
time. So,
Yes. So
Done?
5 minutes less.
let's
He said,
see this and then-
we'll give you 105. So 105, so lunch instead of 45 minutes, 40 minutes, because we have a lot of good food at the boat. Indian, Italian, American, you talk about
Okay,
a lot of good
okay.
food. So little
All
light
right.
lunch, 40 minutes. I need only 5 minutes from you.
all right. Well,
Okay, ready?
show us what you have. Nice.
Good. So now we have to just recross.
But then
Yeah,
quickly.
recross
very
and-
nice
So
already,
recross,
yeah.
kiss.
But recross first. The people want to see the recrossing,
Okay.
and then I'll go to other side.
You
Yeah.
go to the other side, Dr. Sharma, so you can
No,
get
no,
started
we are gonna-
there.
He
As
wants
soon as you recross,
recrossing,
yeah. And then I go
and
there,
then
yeah.
when you are doing kissing balloon,
No,
you are
not
on the
kissing,
other
just
side.
recrossing.
Yeah.
Just
You want
recross.
Just
us to show
recross
you
and go to
how
the other
recross.
side.
The
Yeah.
recross
Excellent.
technique would be the same. We'll use a new fielder wire because of my initial fielder wire that we used. The tip is all gone. Now we go with the new fielder wire. And if we have any difficulty, we'll have to do the pot.
You may have a distal dissection there in the circ, right after the stent.
No, it looks okay. Little botched up.
I think it looks fine. I think
Yeah.
there is some disease. There's disease everywhere. But let's see how
That's
it
how
goes.
calcific complex vessels will look. Oh.
You used to do a lot of kissing stents in the left main. You're not doing that anymore?
Not with the, older generation, which used to be Cypher, Taxus, thicker strut stent, that was very easy. With the this newer generation stent, I think SKS would be much harder. So what I did, I came back, I was able to recross it. Yeah. Now here we may have trouble compared to the first left main where I showed that we'll go with the NC balloon. I'm sure I'll have a trouble going directly with the NC balloon to the circ. So we will go with the 2O. So we'll go with the 2O. Yeah.
But you
compliant
will
balloon.
image this. Will you image this stent in the circ at the end, just to be sure that
12.
John thinks maybe there's a little disruption?
You
Just go back to your previous view without the wire.
You were talking about using the first generation stents, kissing stents, and newer generation do
Look at
not
the outer
stand
portion of
as
that
good.
turn there.
Why wouldn't it work as good as the older generation stent?
No, we are talking about SKS technique. They
What?
were asking, do you do SKS? And I know earlier
Why
they
not?
showed
Why
this
not with the
technique.
newer stents?
There's thin strut. If they have, at all they come back, rewiring and doing PCI through the barrel is way much harder because you can go through the carina in and out with the wires.
So that doesn't look like a cap then there to you.
Yeah, I mean,
It's not acutely. Acutely looks good, but when they come back, if at all they come back, then we really have hard time getting through the carina. So now you see the 2O has gone in easily. See that? So we will dilate here, make some room, and then now give me the LED balloon.
so this is a 2O non-compliant.
2O12.
Just to open the strut.
Start, and then I'll go with
Marie
the
Claude, you have a comment on that teaching point here for our audience?
No. I think it's important because they crush, so there is three layers there. So it's just that a bigger balloon non-compliant might not cross, and I think it's they are on the safe side doing that.
Yeah. Cindy?
So I'm a little worried about crushing the circ stent because there's so much atheroma at the ostium, and so I might have crushed the LAD stent. Actually, I wonder what the rest of the panel thinks of that.
Yeah, I
No,
would agree.
that's a good point.
Plus, recrossing into the LED is going to be a lot easier than recrossing into the circ.
You have the circ stent, what's the 3O balloon? Not yet, don't do it. But I have to get NC
I
balloon.
think I agree with both of those comments. Sometimes I would even come across into the circumflex and then tee it, because I don't think you'd lose the LAD, and it'd be probably an easy T stent to do. The
3O high
beauty of
pressure
this
balloon.
is
3O
that
12
all the
high pressure
vessels are
balloon.
big.
Okay, good, go. Go to the other room. Down.
So
Marie-Claude,
Anu,
you're the-
because we need to get some lunch at some point.
Go.
Tell us what what exactly you're going to do until the end of the procedure. Tell us.
So what I did is I kept the inflated deflated balloon in the LAD, went with the 2O, created a channel for my NC balloon. So we have a 3.5 high pressure balloon in the LAD. Now I'm going with the 3O high pressure in the circ, and we'll do the final kissing balloon.
And you will image the both
from the
limbs.
left main to LAD.
Okay.